Yeah, yeah. All right. Looks like we are live. Uh-oh. Yep, let me sit there. Okay, those of you joining us live, one moment. There are some technical difficulties. It's when everything gets unplugged because it's all gotta reconnect and it's confused. Aha. There we go. Okay. There you go. All right. Maybe now we're live. All right. Good morning, all. Did you guys have a good weekend? Yeah. Over the weekend, you had chapters 8 and 9. 8 was on nutrition. Anybody have any questions about nutrition? Nutrition is a huge subject. I mean, it's like seriously complex. And we really are what we eat. But the chapter of nutrition in the book was basically getting you to understand that different diets are ordered for different conditions. And we've got to make sure that we're following that guideline so that the patient doesn't have any adverse effects. So let me give you a really good example of that. One of the diets that you saw in there was low sodium or no added salt, right? Anybody ever go to the movie theater? People go to the movies anymore? I don't know. When you go to the movie theater, you usually get a big bucket of popcorn. It kind of goes together, right? Well, when you eat the popcorn, it makes you very thirsty. So you usually end up with a big thing of soda. Does that make sense? Right? So you get popcorn and usually a big container of soda. Now, soda has sodium in it too. So I'm going to show you why that's not always the best option, but they go together, right? I can't eat popcorn without soda. They just kind of go together. But here's what happens. We talked about blood pressure earlier in the program, and we learned that blood pressure is the amount of pressure inside the artery or the hose when the heart contracts, right? So if there's more water in the hose, it's going to be a higher pressure. Make sense? Okay. Less water in the hose, lower pressure. So when you eat sodium and that sodium goes into the bloodstream, it's not able to go out of the bloodstream all by itself. It doesn't work that way. So it will eventually be excreted out through sweat or through urine, but when it's in the bloodstream, it can't really go away on its own. So the body, now sodium is a very important electrolyte that is going to affect conduction of electrical activity. So your heart runs on electricity. So your body has to address all of this sodium, has to. Can't just say, don't worry about it. It's fine. Your body has to do something, and it's going to take a while to get it out through the kidneys. So the only other option it has is to push water into the arteries to dilute the sodium. Does that make sense? Okay. So when your body pushes water into the arteries, that increases the amount of water in the hose. So what does that do to your blood pressure? Makes it go up. So when you eat a lot of salt, that's going to cause water to go into your arteries to dilute that salt, and that increases your blood pressure. It will. Because that's just, it's like, you turn the faucet on at the hose, water comes through the hose, it's just, it's a physiological law, right? More water, more pressure. So because all of this water is going from the tissues into the arteries, that makes you feel thirsty, dehydrated. So you generally drink soda to help combat that thirsty reflex. Well, soda has sodium in it. I mean, the first 3 letters tell you everything you need to know. Soda has sodium. So we're putting more salt into the system, which really isn't helping with the whole dehydration issue. So if you're going to have popcorn, much better option is to have water with it. But that doesn't taste the same, does it? So when we have somebody that already has high blood pressure, so they already got a lot of water in their hose, and they eat sodium, things with salt on it, that's going to put more water in the hose, which increases the pressure. So when we have somebody on a low sodium diet, that means something. That means if they ask for a snack, you don't want to hand them a bag of potato chips or pretzels. We need to look for a snack that is low in sodium, like Jell-O. Does that make sense? Okay. So it's important that we understand that what we eat is going to affect how our body actually works. And as CNAs, this is a big issue for us because we're the ones going into the nutrition room and getting the patient snacks. So if you're grabbing saltine crackers and the patient is on a low sodium diet, that means that in a couple of hours, that patient may have some responses to that snack that may have to be addressed by the nurse. Does that make sense? Okay. Does anybody have any questions on chapter 8 and 9? Anybody have any questions? You will have at least one nutrition question on the state exam. You will have at least one. So it does pay to understand that concept. All right, so let me go ahead and get your scores for chapters 8 and 9. Candy? Thank you. Tyler? Josuel?
I don't have that one, but I have 7.
Okay. Okay, thank you. Sonia? Not here. Amaris? Elena? Claudia? Do you have 7 for me? Okay, thank you. Alyssa? No, not Alec. No, stop. Okay. Did I get everybody? I missed you. Sorry. All right. Do you guys have any questions on what we've gone over so far? Any questions on the skills or the discussions we've had, the theory, what you've read in your book? Everybody good? All right, there's only one class left. That's it. After today, there's only one class left, and that's Wednesday. So if you have not registered for the test, this would be a very good time to do so. Because remember, the whole process is going to take 3 to 4 weeks from the time that you register until you're testing. If you wait and wait and wait because you're thinking to yourself, well, I'm not quite ready, I need to practice this or that. When you finally get to register for the test and then you got to wait a whole nother month to actually get to the test, you're going to start forgetting some of the things that I've said. So don't put it off. You guys are way, way, way more prepared than you think you are. Remember, they're not going to compare you to me. They're comparing you to other yous. But I am working very, very hard on these videos, the new ones. You're going to see one of them today. And as I get these new videos up, you probably want to watch them. And the reason is these new videos are a completely different format. The testing checkpoints that you are actually being graded on, the actual checklist is on the screen for every action that I take. So when you're seeing me do something on the bottom of the screen, it's showing you what checkpoint I'm getting checked off for that action. And the two together should really help you understand why each one of these steps are important. Okay? And why, if you miss one of them, that's a checkpoint. Does that make sense? So as I get these done between now and test day for you, you probably want to watch these videos because it's going to give you a little bit better insight into the test process. You're going to see one of them today. I'm going to show you. I worked super hard yesterday to get drainage bag done for you guys so you could see the new format before you left. So, Helen, Miss Patty, can you give me an example of a nutrition question? Sure, absolutely. So this would be a type of question you might see on the state exam with nutrition. You are caring for a patient who is on a low sodium diet. The patient's family brings in food for the patient. Maybe Big Mac and some fries and a soda. You should, as the CNA, A, take the food away from the patient. B, explain in detail with charts and graphs what this is going to do in the patient's body. C, notify the nurse. Or D, ask them if they want their lunch tray too. Say it louder. Why? Okay, that's right. So we only have two doors, right? We either follow the care plan or what happens if we don't? Who do we tell? The nurse. So if you can't follow the care plan or the patient isn't following the care plan, the only other option you have is to tell the nurse. Do you see how these written questions are going to get really simple for you? We don't make decisions. We're not going to educate the patient. That's not our role. Nothing in here has prepared you to do patient education. Nothing. You tell the nurse. Absolutely. So if you can't follow the care plan, we have to notify the nurse. That makes the written test super easy. Now, the only exception to that, and there is a really big exception to that, really big, is in an emergency. Because in an emergency, we don't have time to go tell the nurse. In an emergency, we have to act. So if the patient is having a seizure, you don't want to leave somebody alone who's having a seizure. You've got to protect them from injury. Bonus if you time the seizure so we can let the nurse know about how long this took and yell for another staff member to go get the nurse. If the patient is having chest pain, well, we don't want to just leave them alone and go find a nurse. We're going to stay with the patient, get them to lay down or sit up, get them to rest. But sometimes sitting up can help with breathing, especially if you've got a lot of chest pain, tightness, or difficulty breathing. Send somebody else to go get the nurse. If you see the patient on the floor, the first thing we're going to do is find out, do they need CPR? Are they alive? Don't leave somebody laying on the floor to go get a nurse because the nurse is going to ask, are they alive? Oh, I don't know. I didn't check. So you've got to know in an emergency what action you're required to take. In an emergency, you act first, notify after. In everything else, if it's not a medical emergency, everything else, we either follow the care plan or notify the nurse. If you follow those 2 pieces of advice, you will absolutely pass the written test. Now, the third thing that you need to know about the written test is that we never treat adults like children. And there's going to be a couple of questions on the state exam because CNAs cross this line all the time. It's horrible. Adults are adults. We don't treat them like children. I don't care how dependent they are. You don't treat them like a child. We do not punish adults, no matter how bad you might want to. We do not restrict their activities, even if they're up wandering around at 2 a.m. If you can't sleep and you get up at your house and wander the house at 2 a.m., is there somebody standing there saying, no, 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 you have to go back to bed? You're an adult. You are allowed to wander the house at 2 a.m. if you can't sleep. So we have to be really careful not to cross that line. The ebook that I gave you guys a link for on the first day, that ebook goes over how to answer those written test questions. And if you read through that ebook, it's free. Just go download it off my website. If you read through that ebook, you will make 100% on the written test. It just breaks everything down to make it super simple. Okay. So another nutrition question that you might have, and this one's probably a little more common, is your patient is on a fluid restriction. What items should not be in the patient's room? A, an IV pole. B, a water cup and pitcher. C, a bag of pretzels. Or D, a blanket. B. Now, A was designed to trip you up, though. An IV pole. Is that within the scope of practice of a CNA? No. But you might think fluid restriction, we don't want the IV pole in there. That's not within the scope of practice. Although it may be the right answer, it's not the right answer for you. So even these questions that have absolutely nothing to do with your role may have an answer that has everything to do with your role. That's a nutrition question. But if you answer A, that actually counts against you in knowing your role. Do you guys see that? This test is extremely complex. They didn't just sit around, make up a couple questions, throw them on a computer screen, and that's it. Every answer is designed to lead you in a different direction. This test is 100% psychology. It is extremely complex. The way that I have taught you, you won't have any trouble because I've given you the way to decipher what they're trying to get to. All right. Game show tomorrow. Yay. So, and nutrition might be a good set. I haven't written the questions yet for the game show. I'll be doing that this afternoon. So I might consider nutrition for the topic this time around. So that might be I'll look into that. Can you make a note? Just send it to me in text, please. Maybe I'll consider that. All right. But tomorrow at 11 a.m. on my YouTube channel, I'll be going live. We give away prizes, but it gives you an opportunity to answer the questions in YouTube. So I read a question, you type in A, B, C, D, or 1, 2, 3, 4 is your answer. Hit send, it goes to YouTube. The program I use reads it off of YouTube, and it puts you on a leaderboard, gives you points, puts you on a leaderboard. 1, 2, and 3 get prizes. First place gets a t-shirt, not the one that you have. Second place gets the card game. Third place gets a badge holder. So these are real prizes that we ship out for playing a game and preparing for the written test. How cool is that? Oh, skip that. All right, so we're getting to the point now. It's only one class left. You're probably going to start thinking about, where do I want to work? You know, what should I consider? Should I work in assisted living? Should I work in a hospital setting? You know, where should I look at for possibilities? And the answer to that isn't what you think it is. It's going to have to take into account your personality, not just where you think you want to work. Right now, there's a brand new series, well, not brand new, but there's a new series on called The Pit. Anybody see this or hear about this? The Pit. And it is probably the most realistic portrayal of how an ER works. It's a medical drama. It's very good. But it's actually causing people to think, kind of like Grey's Anatomy, I think I want to work at a hospital. Well, just because you think you want to work at a hospital doesn't necessarily mean that that's the right place for your personality. So you have to look at what kind of things do you like and not like. So this is really going to depend on your personality. And to illustrate this, I want to go over this really quickly. I want you to think about the last job you left. Okay, think about the last job you left, whether you were fired or quit. Think about the last job you left. If you quit, if you made that decision, I want you to think about why. We're not going to say it out loud, but I want you to think about why. Chances are, about 75% of the time, it has nothing to do with the location of your job. It doesn't have to do with the type of work that you did. It doesn't have to do with the shift that you worked. About 75% of the time, it has to do with the people you worked with. Most jobs are quit because of the people that you work with. So if you get into healthcare and it's not the right fit for you, the first thing you got to figure out is, did you pick the wrong place? The second thing you got to figure out is, am I unhappy because of the job or because of the people? Because what ends up happening is you guys just put a lot of time and money and effort into getting your certification. You get into the first workplace and it's not for you. So you quit and you go to work in a completely different industry. You have decided that medicine isn't for you. But is it possible that it may not be medicine you don't like? It might be that you picked the wrong place, or it might be that you didn't do well with your coworkers. If that's the case, give another place a try before you leave medicine. I hate to see you waste all of this time and money and not be able to follow through. Good? That makes sense? So this will help you decide where the right place for you might be. All right, so I'm actually working on this skill, this video right now. I was trying desperately. I didn't get it done. But if you look on page 147, we're going to find out how to help a patient with their bedpan. Nothing new to learn here. If you look down here, all of these principles, we know them all. They're all spelled out here for you. We know all of them. There's nothing new to learn in this skill. Short version up here, video here, down here is your test-specific information. This skill should take somebody with your level of experience 10 minutes or less. But if you look right next to that, it tells you that this is a live patient skill. So that means that somebody in this room will probably be a patient for bedpan. You are going to stay fully clothed. You are not actually going to pee in the bedpan. This is a simulation skill. So the evaluator, if you're the patient for this, will put a patient gown on over your clothing and have you lay down in the bed. You're going to keep your clothes on. Somebody is going to put a bedpan under you and take it out from under you. This skill really is about proper positioning of the bedpan. And you can demonstrate that without somebody actually going in the bedpan, okay? Can't really do this effectively on a mannequin. It just doesn't work the same way. But let's look at this care plan at the top of the page, because it's got some very specific instructions here that we have to look at. It says the resident has requested a bedpan. The resident is not wearing undergarments. Let's stop there for a second. Our care plan says that they're not wearing undergarments. So for the test, if somebody tries to take your clothes off for the test, the evaluator can say, read that care plan. They're not wearing undergarments. So nobody should be trying to take your clothes off, because whoever's testing should know that the care plan has to be followed. The next sentence, or the next part of this says, and is able to wipe self. So nobody should be in your no-no square. If they try, the evaluator can point to the care plan and say they're able to wipe themselves. But that also means that since they're able to, we need to make sure that they have toilet paper to be able to do so. So a big part of this skill is making sure the patient has toilet paper and a call light when you leave. Good? Okay. Step-by-step instructions and supplies are down here. So for the exam, we're going to ask the patient, hey, can you lift your hips for me? Sorry, guys, I'm trying to find something here. Yeah. I'm missing something.
What is it?
Didn't make it's a little Dixie cup that was cut down.
Oh, I know what you're talking about. That may have gotten tossed.
Okay. Well, that's all right. We can use the glass one. Okay. So if the patient is able to move as directed, which our care plan says, we can actually ask this person, hey, can you lift your hips up for me? That makes this skill so much easier. Just have them lift. If they cannot, now they can for the test because our care plan says they can for the test, but if they cannot, we're going to use that whole scoot and roll method that we've learned. We'll scoot them toward us, we'll roll them on their side, we'll put the bedpan against their bottom and have them roll back on top of that bedpan. Now, when you have them roll off of the bedpan, you probably want to hold that bedpan flat though, because when they roll, that bedpan's going to go with them. Good? All right, so let's talk about bedpan specifically. This is literally the last resort. When a patient comes into a facility, as the nurse, I have to assess them head to toe, real problems, potential problems. You've heard me say this before. Well, a very real problem is, how is this patient going to eliminate? Because I know that while they're here, they're going to have to pee. And they're going to have a bowel movement. That is non-negotiable. That happens to absolutely everyone on the planet on a pretty regular basis. I know this is a real problem. So the first question I've got to ask myself is this patient continent? Can they recognize that they need to go? Are they able to hold on to their urine? Are they continent? Now, we learned what incontinence was on the last class. So if they're incontinent, we're going to do pericare every 2 hours, just like we've already learned. But if they are continent, if they are able to hold their own urine and recognize when they need to go, we're not going to ask them to pee their bed. We got to figure out a different way to handle their elimination. So the first question I'm going to consider is, can they go to the bathroom all by themselves? I don't need to be involved, and that's ideal. It's what you guys do. I don't have to help you to the bathroom. You have to go, you get up, you go. You take care of everything all by yourself. That's ideal. We want you to continue doing that as long as you're physically able to do so. You will go to the bathroom and take care of those needs all by yourself. But if you're a little weak, or you've got an injury, or you're hooked up to a million tubes and got that IV pole buddy with you, you might need a little help to the bathroom. That would be bathroom with assist. So if you can go all by yourself and nobody else needs to be involved in this process, we call that bathroom privileges. We're going to let you handle that all by yourself. Take care of whatever needs you've got. I'm not involved. If they need a little help, either getting there, getting on the toilet, getting off the toilet, cleaning up, whatever they need help with, that would be bathroom with assist, whatever assistance they need. Now, if they can't get all the way to the bathroom, so for instance here, if this lady were to get up, that's a long walk down to the bathroom. If she's not able to get all the way to the bathroom, we have a portable toilet called a bedside commode. This is what it looks like. And we bring it right up next to the bed. We'd put it right here. And the patient can get out of bed and onto the bedside commode. Now, this gives the patient a much more natural toileting experience. It feels like a toilet. It kind of acts like a toilet. It just doesn't flush. But it's a pretty good substitute for a toilet. Bedside commode. Now, they may be able to do that all by themselves. Cool. They may need some assistance. That would be bedside commode with assist. CNAs are definitely going to clean out the bedside commode after use. If neither one of those options are open to us, if they can't get to the bathroom or they can't use a bedside commode because maybe they're not weight bearing, maybe they can't put any pressure on their legs. Now we've got two other options open to us, just two. The first is a catheter. And I'm going to consider, is a catheter required for this patient? Now, we don't use catheters for convenience. Catheters have a very high rate of infection, and we're going to talk about that in just a few minutes. But a catheter itself, we don't use lightly. You got to have a reason for it. If the pee can't come out on its own, or if the pee coming out would interfere with something like a wound, a catheter is a good option. But if the pee comes out by itself and the patient doesn't necessarily have a wound or something we're trying to keep dry, the only other option to me is the bedpan. Do you see how I had to go through all of that just to get here? Now, as CNAs, we tend to go straight to bedpan. As a CNA, this is your first stop. But there's some problems here that you probably don't recognize, okay? And one of those problems is psychological. You've been trained since you were this tall. Don't pee in the bed. Don't pee in the bed. Don't pee in the bed. And certainly don't poop in the bed. Do you guys remember me saying that memories that are made when you're young are good quality memories and they stick around for a long, long, long time? Well, when you put a bedpan under somebody's butt Their brain is like, whoa, we're in a bed. This is a no-no. We don't pee in a bed. And when we use a bedpan under a patient, a lot of times we'll get it there and we'll leave the patient for a few minutes. We'll come back and they weren't able to go. So 10 minutes later, we're going to try again. Now, you do this a couple times and most CNAs are going to get frustrated and angry and just go. I don't have time to keep doing this. Your patient can't just go. Does that make sense? Bedpans have a psychological restriction. But there's also a privacy issue here. If you think it's awkward to go into a public bathroom where you are in a stall with walls and a door in front of you, if you still feel that it's awkward to pee with an audience listening, they don't even have walls or a door. There's a psychological restriction there. They may also be concerned about odors. So bedpans are not the ideal solution that CNAs think they are. If the patient needs a bedpan and the roommate is able to leave the room, this is a great time to take the roommate for a walk. Get them out of there. Let your patient have some privacy to go. If the patient seems concerned about odors, you can proactively address that. Maybe a little air freshener or some potpourri or, something like that. If they have trouble starting the flow because of that psychological restriction, we can turn the water on. The sound of running water helps with the urinary letdown reflex. So does warm water on the wrist. So if you put their hands in warm water, that can help as well. So there's some things that we can do to help our patients, but understand that bedpan is a last resort. They're not as easy to use as you would think. Does that make sense? Okay. So we have to put a chucks under this patient. And the reason for this has everything to do with how a bedpan is used. So when we have a patient, let's just say that this is a patient laying in bed, and we put a bedpan underneath that patient, what does it do to their middle? What does it do? The head is here. The feet are here. What did it do to the middle? It raised it up. How many of you ladies can pee uphill? How many of you can have a bowel movement uphill? We need a certain amount of gravity here to help us out. So when we put a bedpan underneath that patient, the most important step is to get the head of the bed up so your patient is in a normal elimination position. This step, putting the head of the bed up, is the most important step with bedpan. Because if that person is able to squeeze the pee out, it's going to run right up their back and into their hair. And that's pretty gross no matter who you are. So when you put a bedpan under a patient, it elevates their middle. We need to put the head of the bed up so that they're in a normal elimination position. But now they're sitting on that bedpan. They're pressing it down into the mattress. You can't get that bedpan out from under them. So we have to put the head of the bed back down so they can lift their hips and we can take the bedpan out. So the head of the bed is actually the most important step for this skill. Putting it up when the bedpan's under the patient, putting it down to take the bedpan out. But with all this movement of the head of the bed, whatever's in that bedpan is going to slosh around. So we need a chucks on the bed to protect the sheets. And we have to put it on so the absorbent side is facing up. When we put the bedpan under the patient, the part that looks like a toilet seat is where the butt goes. Okay, we want the patient to sit on this. Imagine sitting on that. If you put the bedpan in this way, first of all, it forces the legs pretty wide apart, and the patient is trying to balance on this and pee. You're graded on putting that bedpan in the right way. Okay, pretty simple step. Bedpans are going to be in the bottom drawer of the bedside cabinet. And when you look at these bedside cabinets, I have to readjust that. When you look at these bedside cabinets, the top one is going to have grooming supplies. Mouth care, denture care, hand and nail care, grooming. The middle drawer is bathing. Grooming, bathing. Bottom drawer is toileting. Toileting. So it's set up like a person. Grooming, bathing, toileting. All right. So we put a chucks underneath the patient. We already know how to do that. Clean rolls toward me. Get them to lift their hips, roll the chucks under them. And then we put the bedpan on top of the chucks with the wider end underneath the bottom. We know we have to put the head of the bed up. We know that. Do we want to touch that bed controller with butt juice gloves? Your gloves were just under your patient's bare butt. We know that because the care plan said they're not wearing undergarments. So your gloves were just under a bare butt. You don't want to touch that bed controller with butt juice gloves. So we're going to take those gloves off and put the head of the bed up. We'll give the patient toilet paper and call light so they can let us know when they're done. And then once they're done, we have to put the head of the bed back down. Do that before you put your gloves on, because the first thing your gloves should touch is the patient. We'll take the chucks and the bedpan out together, wrap the chucks around the bedpan, and then take it to the bathroom. Where do you think bedpan should be dumped? In the toilet. Don't dump it in the sink. Please don't dump it in the sink. Even though it's pretend, please don't dump it in the sink. Toilet. Then we're going to rinse the bedpan and we're going to dump the rinse water in the toilet as well. We'll clean the bedpan like we clean everything else. Rinse it, dry it, store it. After you get all that done, we'll remove our gloves and give the patient a hand wipe. But I know where their hands have just been. Care plan told me where their hands have just been. I don't have gloves on now because I took my gloves off. I don't want to touch that hand wipe container with soil gloves. That's pretty gross. So I had to take my gloves off to touch that container. Once they wash their hands, that hand wipe, pretty gross. I don't want to touch that with my hands. So what could I use between my hands and that soiled hand wipe? Paper towel, absolutely. Absolutely. Now you can remove the privacy blanket. So one of the things with this skill that I don't agree with, the testing standards and I don't always get along. And this is one of the things that I don't agree with. But I demonstrated the new videos according to the testing standards, even though I don't agree with it. The test does not require that you use a privacy blanket for this skill. The test says that sheet is perfectly okay. Just leave the patient covered with a sheet while they use the bedpan. You don't need a privacy blanket. Guys, whatever's coming out of that patient is going to splash. And that sheet is probably going to get urine on it. And you're touching that sheet with your soiled gloves. I don't like that. I like the idea of a privacy blanket. It gets the sheet out of the way. It's something that's removed from the bed after I've touched it. I like the idea of using a privacy blanket. The video you're going to see today will use a privacy blanket. The new video that I'm currently editing does not, to fully align it with testing standards. You can choose to use one. It's fine, but you're not required to. I don't like that. I think there's a lot of patients out there with urine on their sheets, and CNAs are not addressing it. And I know that because that's happened to my family members. I've walked in, and there's been urine stains on the top sheet. That's pretty icky. Now let's talk about bedpan cleaners. These things are awesome. Awesome. If you go into an acute care setting like a hospital or a rehab, they have, these patient toilets in the patient bathrooms. This is what they look like. And this thing right here, this is actually a bedpan cleaner. It looks like a little mini shower head. And it's always like in the up position with the exposed pipes. It's like in this position. If you pivot that forward, so it's over the toilet bowl, it'll start spraying water. This allows us to clean the bedpan right over the toilet. That way we don't have to go to the sink, which I think is awesome. It allows us to clean the bedpan under the water coming from the bedpan cleaner. Dump it right in the toilet. Awesome. Here's the problem. Big problem. We have water under pressure. It's not dripping out. It's coming out. Water under pressure. Hitting a flat plastic surface that happens to be filled with body fluids. You are going to get splashback. There is no way around it. You will get splashback just because of the pressurized water hitting the flat plastic of the bedpan. You will get, so that splashback is going to go right onto your uniform. That's pretty high on my gross meter. I don't know about yours. So if you're going to use a bedpan cleaner, you've got to dress for the occasion. We know there's going to be splashback. So we're going to put on a disposable isolation gown to protect our clothing while we do this. You probably want to protect the holes in your face as well. Because if there's splashback, it's not just going to go onto your clothing. It's going to get into the holes on your face. So mask with a face shield is something that you should use if you're going to use a bedpan cleaner. Make sense? You don't want to be carrying all of that stuff around on you. Okay. So when we put the bedpan in, there's actually a bit of a problem here because we know we have to put the head of the bed up. We know we have to put the wider end of the bedpan under the patient. We know all this, right? The problem is that bed, when we put the head of the bed up, that bed is going to bend where the patient bends, which is right where we put the bedpan. So when we put the bedpan in place, it's going to be in the right place. But when you put that head of the bed up, that bedpan is going to shift either back or forward. And it's not going to be in the right place anymore. So when we put the head of the bed up, tell the patient you can adjust that bedpan if you need to. It's not going to be in the right place after the head of the bed is up. Does that make sense? Do you guys have any questions on bedpan? It's actually a very easy skill. We're going to do our opening. Knock, knock, knock. Hi, Ms. Jones. My name is Patty. I'm your CNA today. I understand you need a bedpan. Can I help you with that? Close curtain, wash hands, get supplies. Now, I don't like using the overbed table for bedpan supplies. I think that's pretty gross because this is where the patient eats. And even with a barrier, it's just pretty gross to have toileting items on an eating surface. So the video that you're going to see does not use the overbed table. You can use the overbed table for the test as long as you put a barrier on it. It's okay. You can use it. I don't like it, but you can use it.
In the event that they don't want help, do you just give them the bedpan and explain it to them, or how does that work?
That's going to be a very individual situation. I can give you like 30 examples. So let's just say we'll make it very personal. You're in bed and you say, hey, I got to use a bedpan. Can you give me one? You probably, you're pretty small and you're probably pretty agile and limber. So you probably could lift your body weight up and slide a bedpan under you. You are probably one of the only ones that could do that. Trying to lift your butt off of the bed requires counter pressure. We have to put our arms down and our feet down to lift our butt up. So they can't really slide that bedpan under them if their arms and their feet are occupied. So yeah, I mean, you can, if the patient is fully capable and that's how they want to handle it, yeah, that's fine. I'll hand you a bedpan, let you go for it. But I also understand that that's not going to apply to most people. Most people are going to need a little help here. That also doesn't protect the sheets either. So in most cases, this is something the CNA would do. How would I know which patient I need to help and which ones I don't? Care plan. The nurse has already solved that issue. We just have to go by what the care plan says. So I understand you need a bedpan. Can I help you with that? Close curtain, wash hands, get the supplies. We've got them on the table. We come over. You can use a privacy blanket or not, doesn't matter. I'm going to ask them to lift their hips. I'm going to put some gloves on, put the chucks under the patient, put the bedpan under the patient. Take my gloves off, put the head of the bed up. Give them toilet paper call light. And for the test, I'm going to step on the other side of the curtain. Because for the test, I have no other patients. There is nowhere for me to go, nothing for me to do. So for the test, I'm just going to stand here and wait. When they say I'm done, I'm going to come back in, put the head of the bed down, put my gloves on, take the chucks and bedpan out, wrap the chucks over the bedpan because we don't carry an open container of urine anywhere. Take it to the bathroom, dump, rinse, clean, store, gloves off, and skill. In a clinical setting, I'm not going to do this because she doesn't want an audience. It's awkward. Plus, time management, I got other things to do. So if I'm going to leave the patient area, if I've got her set up, she's on a bedpan, she's got her toilet paper, she's got her call light, and I'm going to leave the room to give her some privacy, what do you think I need to do before I leave the room? Okay, call light. Wash my hands. We have to wash our hands before we leave the room. And then we got to wash them when we come back. So for the test, we simply stand on the other side of the curtain. We don't have to wash our hands because we're not leaving the room. In a clinical setting, we're leaving the room. So we're going to wash our hands before we leave. Simple step, but often forgotten. After we return the equipment to storage, we're going to give the patient a hand wipe, use paper towel to collect it, throw it away, and then do our closing. You got 10 minutes to get this done. It only takes maybe 6, maybe. Don't rush this. Remember that nobody's actually peeing. Nobody's actually peeing. So as soon as I step over here, that patient's going to say, I'm done. So I can come back. It's not going to take a long time. Okay, good. All right, Jake, can you put bedpan video up for me, please? And then mute me.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I understand you need a bedpan. Can I assist you with that?
Sure.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, I'll need a Chucks and a privacy blanket for this skill. Okay, Mr. Jones, I'm going to place this privacy blanket over you. This will help keep you warm and protect your privacy as we do this skill. Is that okay?
Yes.
Okay. I'm going to spread this out without snapping it or shaking it. And I'll have you hold this in place so I can pull your sheet down. That way your sheet remains clean as we do this skill. Okay, I'm going to prepare a Chucks to place under you before we put the bedpan in place. I'm going to hold the Chucks up lengthwise and roll it toward me. Clean rolls toward me, dirty rolls away. And I'll just place this on the bed. I'm going to open the drawer that the bedpan is in and get a set of gloves. Okay, Mr. Jones, in just a moment, I'm going to ask you to bend your knees, lift your hips as high off the bed as you can, and I'm going to unroll the Chucks underneath you. Okay?
Okay.
All right, go ahead and bend your knees and lift up. Okay, and you can relax. I'm going to go around to the other side of the bed and unroll it. Okay, Mr. Jones, can you lift up again, please? I'll smooth the Chucks out, making sure it's positioned properly on the bed. You can relax. Okay, now I'll get the bedpan out from in the drawer. And I'm going to place this under your bottom, if I can get you to lift and relax. Is that comfortable?
Yes.
Okay, I'm going to put the head of the bed up, but let me remove my gloves first.
Okay.
Okay, I'm going to put the head of the bed up. Please tell me when you're comfortable.
Okay.
And you may have to adjust that bedpan a little bit as it moves. Tell me when you're comfortable.
That's good.
Okay, here's your toilet paper and your call light. And I'm just going to wait out here. Please let me know when you're done. Okay, Mr. Jones, I understand you're finished. Let me help you with that. I'm going to put the head of the bed down now. And please do not lift your hips. Once the head of the bed is in the lowered position, I'll put on a pair of gloves. And I'm going to hold that bedpan flat as you lift off of it. Okay, Mr. Jones, I'm going to take a corner of the Chucks and hold the bedpan flat as you lift off of it. You can go ahead and lift on the count of 3. 1, 2, 3. Thank you. I'll remove both the bedpan and the Chucks and take them to the bathroom for disposal. I'll be right back. Once I get over here to the bathroom, I'm going to unwrap the bedpan and we'll throw the Chucks away. I'm going to empty the contents of the bedpan into the toilet, and then I'll rinse the bedpan. We'll deposit the rinsed water into the toilet as well. And then we'll set the bedpan down to dry. I'll pick it up with a paper towel. I'm going to dry the inside. We'll throw that paper towel away. I'll dry the outside, throw that paper towel away, and get one for the drawer. Okay, I'm going to place the bedpan in the drawer along with the toilet paper. And we'll use the paper towel to close the drawer. Now I can remove my gloves. Mr. Jones, would you like to wipe your hands? Thank you. Okay, you can relax your legs if you'd like. And I'm going to pull your sheet up and remove the privacy blanket. Want to make sure that we roll the blanket in a ball so that any trailing edges don't contaminate other surfaces. There you go. Here's your call light. I'm going to go put this in dirty linen. I'll be right back. Okay, Mr. Jones, are you comfortable? Is there
Yes.
anything else I can get for you while I'm here? A
No.
magazine,
Thank you.
perhaps? Your call light is there. Please let me know if there's anything that we can do. I'm going to open your curtain and go wash my hands.
Thank you.
After washing my hands, I'll review the steps of my skill, make any corrections, and then tell the evaluator my skill is done. And just because, again, it's in a medical setting, we think that everything in here is ours as healthcare workers. It's our furniture, our bed, ours, ours, ours. Your patient is paying for that space and everything in it. It is not ours, it is theirs. So if you're going to reach into that bedside cabinet, they will probably automatically assume that you are there to take whatever they have. And unfortunately, this has happened many, 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 many times. Jewelry goes missing in healthcare, cash goes missing in healthcare, wallets and credit cards go missing in healthcare. We just had one here in this community about 2 months ago. A healthcare worker was charged with taking a patient's credit card from from an assisted living facility and charging something like $30,000 of products on that card. So if you're going to be in their space, they probably need to know what you're getting. So I'm going to get your bedpan out of the drawer. I'm going to get your toothbrush out of the drawer. Otherwise, they probably are going to assume the worst. It's horrible. One of my students, and this just breaks my heart to say this, but about 7 or 8 years ago, one of my students was arrested and convicted of grand theft, stole big amounts of cash. I think it was $5,000 the first time. And the second time she went in, they actually, because the patient reported it, they actually set up a sting operation, and she was caught stealing something like $10,000 or $12,000 cash from the patient. So this happens with my students. That's why I have to talk about it. We can do better. Any questions on bedpan? All right. We're going to go ahead and take our break a little early today. And that's because the next two skills I'm going to teach together. They're two separate skills, catheter care and emptying the drainage bag. But I'm going to teach them together because they do go together, even though for the test they're two separate. I'm going to teach them together, and it's going to take me a little bit of time. So let's get our break out of the way first, and then we'll get into those. And the rest of the class will be practice today. Okay? Can you... We're alive. All right, so we're going to move on to the last two skills. This is it. Class went pretty fast, didn't it? They always go fast for me, but this one seems to really have sped by. It's kind of crazy. All right, so these are the last two skills we have to learn. Catheter care, which is pericare with an extra step, and emptying the drainage bag, which kind of goes along with catheter care. Usually when we're doing catheter care, we're also emptying the drainage bag. That's why I like to teach them at the same time, because they do go together in a clinical setting. For the test, though, just because you get one doesn't mean you're going to get the other. So remember, for the test, they are two separate skills. All right. So if you go to page 158, nothing new to learn. All of the principles are spelled out here, and we know all of these principles. There's nothing new here to learn. This is a long skill. Somebody with your level of experience should be able to do this skill in 15 minutes or less. But if you remember, pericare was 17 minutes. Now, I told you, this is pericare with an extra step. So if we've got an extra step, but they're giving us less minutes to do it, that can be a little anxiety-inducing. So the reason that we have less time to do this is because it is pericare with an extra step, but we're going to get rid of a step that took the most amount of time for pericare. And by that, what I mean by that, let's go to page 159 and look at the care plan for instructions. Care plan says, provide catheter care with soap and water to a female resident with an indwelling urinary catheter. Clean the catheter tubing and perineal area only. So our care plan is telling us we're going to clean the tubing and the peri area. We're not going to clean the butt. Remember, with pericare, we had to turn the patient over, wash the backside, rinse the backside, dry the backside, and change the chucks. That was a large part of pericare. We're not doing that with this one. So even though it is pericare with an extra step, we're getting rid of the biggest step in pericare. Along the bottom, you can see your supplies. Very, very, very similar to pericare. So if you remember pericare, we use that leaves method. We change the chucks. We use the leaves method. We clean top to bottom, middle, side, skin fold, rinsed, dried the same way. Turn the patient over. We cleaned up the middle crack, one cheek, the other cheek, up the middle crack again, and then change that chucks again. This was pericare. So when we get into catheter care, it looks very, very similar. We're going to put our chucks under them. We're going to clean the peri area exactly the same, but we're not going to clean the backside. We're also not going to leave them on a chucks. So I want to talk about that real quick, because that step, a lot of students skip over. We want to remove the chucks that's under them. We're going to put it there to keep the sheets dry while we're cleaning. We're going to take it away at the end because those chucks are plastic lined. They're going to hold in body heat. So if we have body heat held in, no way to dissipate, it's going to make the patient sweat. So now we have warm, dark, moist, which increases the bacterial load in that area. If we take the chucks away, the patient is going to sweat less, and we're going to reduce the potential infection risk. Now, with pericare, we need the pad there because they're incontinent. But with this skill, we have a tube collecting the urine, so we don't need the pad at the end. Make sense? All right. So this skill is not a hard skill. It really isn't. It's actually a little bit easier than pericare overall. But the hardest part of this skill is learning what a catheter is and how it works. So that's what we're going to go over now. Because if I don't teach you this, if I just teach you how to clean the tubing and how to clean the peri area, you'll be able to do the skill, but you're always going to be fearful because you don't understand how the system works. I want to try to remove that fear so you can perform competently. So catheter care is usually done once a shift, and it means that we're going to clean the tubing, and we're also going to clean the skin around the tubing. That's all we're doing here. And it's usually done once a shift, but we're always going to follow the care plan for that particular patient. If I have a patient on chemotherapy and I'm actively killing their immune system, catheter care may be twice a shift. Does that make sense? Okay. When we're doing catheter care, cleaning the tubing and the peri area, we're also going to inspect the bag. The bag should always be hanging from a non-moving part of the bed. It should be above the level of the floor. We don't want those bags to touch the floor. And the tubing should be coiled on the bed, not hanging down toward the floor. Now, this is for drainage purposes, because if that tubing is hanging down and then has to come up to the bag, well, it's liquid. Liquid can't go uphill, not by itself. So you don't want that tubing to hang down because it's not going to drain properly. But you also don't want it hanging down because it becomes a tripping hazard. So this is the anatomy of a catheter and a bag. So up here, this is the part of the catheter that goes into the patient. We're going to talk about that in a minute. This is the exposed catheter tubing that we can see when somebody has a catheter. And it's going to terminate with two little ports. One port is going to attach to a bag, a collection device of some sort. The other port is used to inflate and deflate that balloon. That balloon serves one purpose. It holds the catheter in. It's a doorstop. That's it. But we have to have a way of inflating it and deflating it. Can you imagine pulling that out? That would hurt. So we deflate it before we remove the catheter. This is the bag, the tubing. It empties into the bag. Bag's going to have markings on it. We can use that for a general eyeball, but that's not how we measure urine. We actually empty the bag into a measuring cup to measure urine. This is the port we use to empty the bag. And then this little thing is a little house that the port lives in. So catheters and bags are two separate pieces. Okay. This is a catheter. This is a bag, two separate pieces. They're going to attach together with the port. This allows us to change the bag more often than we change the catheter. Catheters can stay in up to 30 days. Bags are generally changed once a week. CNAs, unless you have been trained, do not separate these two pieces. Not our job. You can be trained to do that. But as of right now, you've not been trained, not your job. Because when we separate these two pieces, we now have a direct line for bacteria to enter. So you have to be trained. Good? Catheters can stay in place up to 30 days, but drainage bags are going to be changed more often, typically about once a week. Now, it depends on the patient. Again, we're going to go by that care plan. Some facilities will train you to change the bag as long as it's a routine task on a stable patient. So you wouldn't be changing bags on patients that have active urinary tract infections. Stable patients. Does that make sense? All right. So these two things together, when they're joined, is a closed system. One end is inside the patient, and there's nowhere in between for bacteria to enter. Closed system. The only place bacteria can enter is through here. It's closed. Now, if as CNAs we come along and separate these two pieces, now it's no longer a closed system and bacteria can enter. This is what they're grading you on the state exam. If you separate these two pieces on the state exam, you will fail. I can't tell you how many people for the exam separate these two pieces. And that's a huge risk for the patient. I know, kind of crazy, right? All right, so chain of infection here. We've learned about this. We learned about this on class 2, way back when. We know that pathogens need a place to live. They have to have a doorway out, and then they have to have a way of getting around. Once they get somewhere else, they've got to find a doorway in. That person needs to be susceptible, and now they are a host. We've learned all this. The problem is that the number one healthcare acquired infection, we used to call them nosocomial infections, but nobody could spell that. So we changed it to healthcare acquired infection. What that means is the patient comes in, they don't have that infection, but sometime while they're here, they develop it. So they got an infection while they were receiving healthcare acquired infection. The number one healthcare acquired infection is a urinary tract infection, specifically a catheter associated urinary tract infection. And you're going to hear this term a lot in healthcare, a CAUTI. This is the number one risk for patients that have catheters. And it is super, super dangerous. These are not the run-of-the-mill urinary tract infections where you get a little burning, a little pain, a little urgency. That's not what this is. And let me explain why. These things kill about 2,500 people a year. A catheter-associated urinary tract infection kills about 2,500 people a year. This is not something to sneeze at. So if we remember what we learned last week, we have kidneys. Those kidneys filter blood, produce urine 24 hours a day, drip, drip, drip. Those drips come down tubes called ureters and collect in the bladder. Valve at the bottom of the bladder holds the urine in there till you go to the bathroom. Valve opens, urine comes out. We remember this from last week. So what's happening when we put in a catheter? The only thing the catheter is doing, the only thing it does is holds that valve open and gives the urine a tube to go down. So remember when the valve didn't work, it made our patient incontinent? You guys remember that? Valve doesn't work, they're incontinent. Well, what we're doing is making the valve not work. So the patient is, by definition, now incontinent. So urine is just going to flow right out. Valve doesn't work. We don't want the urine to just flow right out. We want it contained. So this tube acts as a straw. The urine goes into the tube. The tube is holding the valve open, and the urine just flows out. So it's controlled incontinence. Does that make sense? Controlled incontinence. Now, the only thing that this balloon is doing is holding that tube in place. Do you see where that balloon is positioned? Right there at the top of the valve. If we didn't have that balloon, see the tube here in the urethra? That tube would just slither right out. It wouldn't stay in. There's nothing to keep it in. So when we put the catheter in, we inflate this tube. It sits right at the bottom of the bladder, and it acts as a doorstop. It just keeps that tube from coming out. When we want to remove the tube, when it's time for the catheter to go away, we're going to deflate that tube, and it just slides right out. If you don't deflate that tube, that bubble is going through an area that wide. That's going to cause some pain, some tissue tearing, some bleeding. We're going to talk about that in just a few minutes. So we would definitely want to deflate that balloon before we pull a catheter out. CNAs can be trained to remove catheters. You can be trained. It is as simple as taking sterile water. The nurse puts the water in when they insert the catheter. So the catheter is inside the patient. The nurse inflated the balloon, and now the catheter stays in. We can tug on it a little bit, and it's going to stay there. Tug on it too hard, and it's going to come out. When it's time for the catheter to be removed, you just take a syringe, and you pull the water out of the balloon. And it slides right out. So CNAs can be trained to do that. It's a routine task. As long as your patient is stable, you can be trained. You're not going to do it until you're trained. Training is not part of initial certification. So this system, the nurse puts the catheter in, inflates the balloon so it stays. Urine is going to go down the catheter tubing into the drainage bag tubing, and finally into the drainage bag itself. Guys, this is nothing more than this on the outside of the body. That's it. The bladder holds urine. The bag holds urine. In fact, the word bladder actually means bag.
Will the patients ever try to take it out themselves?
We're going to talk about that. Yes. Ideally. But yes. So we have a bladder. We have a catheter in the bladder that's being held in place by a balloon. And that catheter is going to have to attach to some sort of a bag, a collection device. And there are many, many different types of collection devices. The one that's most common in a clinical setting is this one. It's called a bedside bag. That's what you see here. This is a bedside drainage bag. It's big. It holds 2,000 cc's of urine. That's a lot of urine. A lot of urine. Like 5 pounds of urine. So we don't want it to get too full. If it gets too full, it can't hold anymore, and it's heavy, which is going to pull on this. So we're going to have to empty the bag periodically. This is what's used in most clinical settings. But when your patient is out and about in the community, we generally don't carry a suitcase full of urine with us. That's embarrassing. We want something more discreet. So those patients would use something like this called a leg bag. It velcros or attaches with elastic straps to the inside of the thigh or the calf. And it, just like this, is going to just hold urine. But it's more discreet. It can be hidden under clothing. Your patient may have this at night when they're in bed and this on during the day when they're out and about. Make sense? 2 different types of bags. Back here. But they both attach to the catheter the same way. So this is what a leg bag would look like if it's attached to the inside of the thigh. It can also, if the thighs are too big, it can be attached to the calf as well. but it's going to have a little drainage port at the bottom. And all that does is unscrews. Just unscrew it, urine comes out, and then close it back up again. You don't want to leave these bags open. Number one, urine's just going to come leaking right out. But number two, an open bag means bacteria can get in. So a big step for this is going to be making sure that you close the port after you empty. So that brings us to the port. This bag, the port is right here. It has a little house that it lives in. We take it out of the house, and there's a T-valve. We're going to slide the T-valve to the side to open it. So if you look through here, right now it's closed. You can't see through. If you open it, now it's open, and the urine can come out. To close it, we would just push it to the side again. When you do that, you don't want to touch this area. This is where bacteria are going to enter. If we let this port touch anything, our fingers, the floor, the bed, the drainage cup, whatever, it's going to allow bacteria in. So what they're looking for when we do this skill is not letting that port touch anything. Once we're done, we're going to make sure it's in the closed position and then just slide it right up inside its house without letting it touch anything. So we're not going to... Right, right. So we pull it out, we open, we empty, we don't touch the port, we close, and we put it back. This is probably the easiest skill there is. It really is, but it's 100% infection control. This skill is 100% infection control because of this, what I'm about to show you. If we allow pathogens into this bag through that port, so we're not careful, pathogens got on the port, we didn't close it, so they got in the bag. When pathogens get into this bag, it is the ideal breeding environment. Urine is warm. It's got lots of enzymes and proteins that those bacteria need to procreate. And by the way, bacteria don't need boy bacteria and girl bacteria. They just need the right stuff, and they zip themselves in half, and now we have two. So one bacteria in this bag can very, very quickly turn to 2, 4, 8, 16, 32, 64, 128, 256, 528. It just goes on, or it goes on and on and on. Binary, actually. So every single time, the whole population doubles. Doesn't take long to realize that when that happens, this whole bag is going to get full of bacteria. There's no room for them. So they start traveling and they move up the tubing. Now, thankfully, this bag and tubing is clear, so at least it's not dark. We don't want to put the bag in a fabric bag, because now we've blocked out light, warm, dark, moist. If it's not dark, we're going to help control that bacteria proliferation. When you put this in a fabric bag to kind of conceal it, you're now introducing dark. Does that make sense? That's not good. So as this bacteria starts to climb, once it gets into this catheter, now the catheters are dark and the urine is fresh and hotter. So by the time the bacteria get up here, man, they are just rolling right along, rolling right along. So the only exit to this system is inside the bladder. So those bacteria, when they come out of the holes at the top of the catheter into the bladder, it's not 1 or 2. It's 1 or 2 trillion in 15 minutes. They go from perfectly fine to overwhelming invasion. No warning. No warning. Now, we aren't putting catheters in healthy people. This person is fighting something else off. Injury, illness, surgery, whatever. They have had trauma to their body. So their white blood cells are currently fighting a war way over here. We get an overwhelming invasion in the bladder. There's nobody to fight it. That's why catheter-acquired urinary tract infections kill about 2,500 people a year, because there is no way to stop this from happening. Way bigger. Way bigger. And it's really, really hard to get control of. Now, inside this bladder is nirvana. I want you to think about the best vacation spot you can absolutely envision. Best vacation spot. Open bar, free buffet, sun, fun, massages, all of that is in the bladder for these bacteria. It is the ideal vacation spot for them. Every bacteria in the world is trying to find a bladder to get into. Everyone. Because the proteins and the enzymes inside that urine make it the ideal environment. They can eat like there's no tomorrow. And that is what really puts our patients at risk. So the biggest part of this particular skill is not letting any pathogens in the system. That's what they're grading you on. Good? Ick. Ick. There's only 3 places that bacteria can enter the system. This one, where it goes into the body, that's the nurse's responsibility when she's putting the catheter in to make sure that she doesn't bring any bacteria with it. Sterile process. Here, where the catheter and the tubing meet, which is open when we change the catheters, and down here, the port that we empty the catheter from. So these 3 places are where bacteria are likely to enter. This one's inside the patient. Once catheter's in place, it's safe. This can only be separated with additional training, but this we do. So we have to understand this whole infection risk to understand that what we do here is going to matter. Now, thankfully, this is as far away from the patient as you can get. I mean, these bacteria have to work really hard to get there. So we're separating it by space, but that's why this is really close to the patient. That's why you have to have additional training to separate it here. The number one mistake made on emptying the drainage bag for the test, the number one mistake made by students is they separate this and take the bag to the toilet to empty it. That is the number one error made during testing. They separate this and take this to the bathroom. As long as you know not to do that, you're going to be fine on this scale. Now, drainage bags should be above the level of the floor. We don't want that drainage bag to touch that floor because the drainage port is there. We don't want bacteria. Drainage bags are also called catheter bags. You'll hear them called that quite a bit. But you also don't want to lift that catheter or that bag above the level of the patient's hips. So if this person has a catheter and I pull this bag up, whatever is in the tubing is going to wash right back into the patient's bladder, along with any bacteria that might be in that tube trying to make their way. It's like a water slide. All kinds of fun for the bacteria. I don't know about you, but recycled urine, pretty gross. Urine should be a one-way trip. When you lift that bag up, you are washing all of that urine right back into the bladder. That's gross. If you ever watch any medical dramas or medical shows on like TLC or whatever, you'll see it happens all the time. You'll see that, techs or patient care assistants or patient care techs or, whatever you're called in that facility will be walking a patient down the hallway and they'll have the catheter back up here. And it's like, oh my gosh. Or they'll hang it on the IV pole.
Okay.
Recycled urine. Pretty gross.
Mm-hmm.
But it also increases the infection risk in a very, very big way. So don't do that. And yes, sometimes patients will pull these catheters out, particularly if they're confused. This happens, but you don't have to be confused. Sometimes you can just be angry. Now, when a patient pulls the catheter out, it's going to hurt because you've got that big balloon going through a tube that's only about that big. It's going to hurt, but it's not going to kill them. They're going to be fine. However, they probably tore their tissue pulling that balloon out because the balloon wasn't inflated. They pulled it out. So you're going to see some blood. Don't panic. Your patient will take their clues from you. If you go, oh my God, you pulled your catheter out. Oh my God. And you start freaking out, your patient's going to start freaking out. So they're going to take their cues from you. Don't freak out. Okay, I see you pulled your catheter out. So now we got to figure out what we do with the catheter that's been pulled out. You don't want to just throw it away because as a nurse, if my patient pulls that catheter out, I've got to look at it. As long as the whole catheter came out, we're good. I can deal with that. But if a piece of the catheter stayed in the patient, I can't deal with that. That now becomes a surgical issue. The only way for me to know, because there's no, like flashing light above the patient's head that says, hey, something stayed in me. It doesn't work like that. The only way for me to know that that happened is to look at the catheter itself, make sure the whole thing is intact, and then I can figure out what to do. About 1 out of every 100, when this gets pulled out, the balloon actually bursts and can leave a piece of itself behind, particularly if the catheter has been in a while. Because the acid, remember, urine is acidic. Remember we talked about that? The acid of the urine can eat away at the material of the catheter. And if that happens and that balloon bursts and leaves a piece of itself behind, we've got to go in and get it. Can't just leave it in there. So if a catheter comes out, whether the patient pulled it out or something else, if that catheter comes out, don't hide it and don't throw it away. We're going to put it in a bag, just a trash bag. There's always extra trash bags in the bottom of your trash cans. Get a bag, put the whole thing in it, the catheter, the bag, everything in the trash bag, put it in the patient bathroom, and then go let the nurse know, hey, patient pulled the catheter out. It's in the bag in the bathroom for you to inspect. Now, as a nurse, I got to figure this out pretty quick because anytime there's injury, there's always swelling. Always. Because white blood cells have to go to the area to fix whatever happened. So there will be swelling. This is not a place we want swelling. So if I've got to put another catheter in, I've got to do it before the swelling sets in, which takes about 30 to 45 minutes. So if you have a patient that pulled a catheter out and you don't come tell me until an hour later, I have no choices. I have nothing I can do. The swelling is already there. I can't put another catheter in. Now, can you imagine peeing through that swollen, torn tissue? Do you know what that's going to feel like? It's like peeing razor blades. So if the patient needs another catheter, we've got to get it done quickly. If we don't put another catheter in, this patient's going to need some pain medication. Either way, I got to be involved. Make sense? But as bad as that is, I can't imagine pulling out my own catheter. That would be pretty crappy. As bad as that is not how most catheters come out. This is. CNAs pull out way more catheters than patients do. Way more. And it usually happens because our feet get bound up in that tubing. And as we try to get our feet out, we pull the catheter out. But that's not the only way that CNAs pull catheters out. When you're turning a patient over in bed, you need to look for a catheter because as you're leaning against that bed, your leg can trap that catheter between you and the mattress. You turn the patient over and just that simple action of turning them over can cause that catheter to come out. Transferring a patient from bed to wheelchair. If the catheter bag is on the other side of the bed and you don't know they have a catheter, you will absolutely pull it out. But the number one way that catheters get pulled out by CNAs is this. CNAs will get a patient up to take them for a walk, and the catheter bag stays on the bed or the chair. And the patient will walk right out of that catheter. They'll feel a tugging, and by the time they realize that there's a tugging going on, that balloon has already come out. So if we're going to ambulate a patient or transfer a patient, what's the first thing you should look for? A catheter bag. Now, it may not be on the care plan. If that nurse just put a catheter in and hasn't had a chance to update the care plan, there may be a catheter that you are not aware of. So you have to look. If that patient is going to move in any way during this skill at all, you need to look for a catheter bag, because chances are you're going to be the one that pulls it out. Yeah, observation. And the thing is, patients that are pulling on a catheter, you can only tug on it so hard and it's going to come out. But you know, that causes like a pulling sensation. So most patients that are pulling on the catheter will stop because they can feel what it's doing. Unless they're, you know, determined, they're going to stop. For us, if we're rolling a patient or transferring a patient, we don't stop. We just keep going, because we don't have the sensation that the patient is feeling. We just keep going. And that's why we end up pulling out way more catheters than patients do. The number one issue that we have with catheters is that staff members pull them out and don't tell a nurse. They leave it for the next shift. Happens all the time. All the time. Leaves it for the next shift. Because you don't want to be yelled at. Does that benefit the patient?
I think the CNA should get over it. You did something wrong, tell the nurse.
Absolutely.
You get yelled at, you're wearing a bag, don't do it again.
Yeah, exactly. You learn to look. Yeah, you will make mistakes, guys. You will. You are not going to be perfect when you get out of this class. You are not going to be perfect. You will make mistakes. I still make mistakes. In fact, the video that I'm going to show you that I just did, there is a mistake in it. I'm going to see if you guys pick it up. It's a very minor mistake, but I'm going to see if you guys pick it up. We all make mistakes. What sets apart a professional is owning up to them and looking to improve. You will make mistakes. So if a catheter does come out, put the catheter, the bag, everything in a trash bag in the bathroom. Notify the nurse right away. There's a couple of different types of catheters. Now I'm going to pass this around so you guys can see and you can play with it. Okay. This is the catheter attached to the bag. This is the water that you can inflate and deflate the balloon. But I find that by letting you guys see all of this and work with it, it reduces your fear of this system. All it is a straw. That's it. It's a straw. Flexible, but it's a straw. So I'll let you guys kind of play with this. There you go. There's a couple different kinds of catheters. Oh, Helen, if, for example, a patient pulls a catheter out in the presence of a CNA, my question is, does the CNA have the right to touch the catheter or just leave it there and report it to the nurse? No, you can touch it, but should you touch it without gloves? Body fluids, right? This is definitely body fluids. So you want to put on a set of gloves, put it in a trash bag along with the drainage bag, put it in the bathroom, and then report it to the nurse. But don't leave it there. That's kind of, can you imagine being the patient laying in bed and you've got just like this catheter that came out of your body laying in bed with you? That's a little creepy. So don't leave it in bed. All right, so this is what we've been talking about so far is an indwelling catheter. It's also called a Foley cath. Everything in healthcare has two names. Sometimes they have three. We're going to get to that in a minute. But an indwelling catheter has the balloon on it. It's designed to be put in, the balloon inflated, and left in for up to 30 days. This is most commonly called a Foley. But not always do we need to leave that catheter in. Sometimes we just want to put it in to drain the bladder and then take it back out. In that case, we don't need a balloon. It's not staying in. This is called a Red Robinson or a straight cath. It's also called an intermittent cath. So we get 3 names for this guy. Straight cath, intermittent cath, and Red Robinson, all the same thing. It's a different color and no balloon. This is designed to literally go in, drain, come out. It doesn't stay. For men, we have a different catheter option, and that's an external catheter, also called a condom cath or a Texas cath. Again, 3 names, same item. This goes on just like a condom. It's sticky, adhesive on the inside, and it's designed to stay on for about 3 days. The bag that you guys just saw, the port that connects to the catheter would connect to this. But there's a problem with these. Now, it's nice because you don't have anything inside the patient. So we've reduced that bacterial risk. So this is nice for reducing the risk to the patient, but remember, adult urine is acidic. So we have the bag attached to this port. The shaft of the penis is down here, but there's this little area right here called the reservoir that's going to be between the tip of the penis and the port that's going to pull the urine away, or, allow the urine to drain out. That little reservoir is going to hold urine right up against the tip of the penis. Urine is acidic, so it could eat at that skin. So when we change this catheter, and you can be trained to do this, but when you change this, the most important step is to do super good peri-care, clean this area really, really, really well, and we're probably going to put a protective layer called a skin prep. It looks like an alcohol pad, but it provides a protective layer between the urine and the skin. Now, again, you'd have to be trained to do that.
Now, in the kit, does it come with the example that you have right there? The kit that some people want.
Yeah, our practice kits have the drainage bag. I don't have the catheters in there. You can just use a straw and tape and pretend. I don't put catheters in because unfortunately, I can't guarantee that they're not going to be used on a live person. I just, once that kit gets out of my sight, I can't guarantee what's going to happen with it. And catheters are they're a medical device. So I have to be very careful about that. So you won't have the catheter, but you can certainly get away from it just by putting a straw in there and pretending. All right, so everybody understand the different types of catheters? Okay. So how do we do catheter care? Well, it's actually pretty easy. We're going to hold the catheter out of the way and we're going to do peri-care. Middle, fold it, side, fold it, skin fold it, skin fold. We've learned how to do this. And then we're going to clean the tubing. Remember, we always move away from the urethra. Then we clean the tubing, but we want to hold that tubing where it exits the body so that as we're wiping down the tubing, we're not pulling it on the inside. So we want to hold that tubing in place as we clean because you don't want to tug on it. So here's our skill. We're going to perform catheter care with soap and water to a female resident with an indwelling urinary catheter. We'll clean the catheter tubing and perineal area only. So that means we'll do our opening. We'll put our barrier on the table and get our supplies. We'll get the water. We're going to check it, and they're going to check it. We're going to put a privacy blanket on the patient, pull the sheet down, put on some gloves. First thing your gloves should touch is the patient. We'll have them scoot and roll so that we can put a chucks under the patient to protect the sheets while we clean. Once we get the chucks under the patient, we'll roll up the privacy blanket and put a towel over their legs, just like we did with pericare. Again, this is pericare, guys. It's pericare. So once we get them prepped, we're going to wring out those washcloths and apply soap. This is a wet body opening, so we're going to soap all 5 leaves. Once we get the soap on the leaves, we're going to hold that catheter and we're going to wash, moving away from the urethra. Middle, side, skin fold. Whatever we wash, we rinse. Whatever we rinse, we dry. And then we're going to clean the tubing. So we'll wring out washcloth number 3. We're going to soap 4 leaves. We're going to hold the tubing and wipe away from the urethra 4 times. 1 fold, 2 fold, 3 fold, 4. Whatever we wash, we rinse. Whatever we rinse, we dry. Cover the patient up, take care of all of your supplies, get rid of that chucks underneath the patient. We're going to put all of our soiled items and dirty linen, return our basin to storage, remove our gloves, get rid of that privacy blanket, and do our closing. This is a long skill. 15 minutes, but it's not a hard one. It's not a hard one. All right, so let's, okay, because I want to show you these 2 videos back to back because they do really go together. Let's jump into drainage bag. This doesn't take me very long to teach you because we already learned pretty much everything we need to know. Go to page 164.
For the exam, are we being checked on using an alcohol pad?
No, that's a great question. And in fact, the video that I posted yesterday, that was a question that somebody asked. You know, you didn't clean it with an alcohol pad or wear a gown while you were emptying the bag. Now, a gown is going to depend on the care plan. Our care plan did not tell us to use a gown, so we didn't need to. And cleaning with an alcohol pad, this is going to be based on your facility policy. Some facilities want the port cleaned with alcohol, certainly. But what we have found, it used to be standard practice, but what we have found, because we do evidence-based practice, so what they have found is that alcohol pad actually dries out the material of the port. And when it dries it out, it's called desiccation, actually. That's the clinical term. It desiccates the material, and that causes microcracks to form, which is the ideal area for bacteria to hide. So it actually increased the infection risk, the bacterial load of the bag. So they have determined that that is no longer best practice. Again, you're going to go by your care plan for that patient. But that's why we don't do it for the test, because it is no longer considered best practice. Now, that brings up a very important point. I have taught you to do certain things, but along the way in your career, somewhere down the road, somebody's going to realize that what I taught you may not be the right way of doing things. We've learned something, we've changed the standard, but you're already working and you're doing what I taught you to do because you're already working. So how do we get this new standard out to you if you're already working? Well, we do it through something called continuing education. So in order to renew your certifications, you are going to have to take a certain amount of continuing education, which ideally will focus on changes and procedures that have been put in place in order to renew. You need 1 hour of continuing education for every month that you are certified. We'll talk about that in detail on Wednesday. But that's how we get changes out to the community, because people that became a CNA 10 years ago, they're still using alcohol pads, even though we now know that that's not best practice.
Would you be respectful of the challenge of facility? You know, on things that you've learned and bring it upon them, or is that
Sure, absolutely. And
get turned down?
it depends on management style, but you can certainly ask, We learned in class that we don't use an alcohol pad because current best practices indicate that it causes microcracks. So I just want to verify that your facility does in fact want us to use this procedure. And, it's perfectly okay to present it in that way. What you don't want to say is, that's not how I learned to do it. Because that kind of puts your employer on the defensive.
I just have, like, if you're a nurse saying, oh, that's not true, just like,
hmm
then I have to figure out how to respond to that. Like, well,
Remember that the nurse is,
continuing education that has now
yeah,
proven otherwise.
that nurse, unfortunately, is the one that's legally liable for the patient. So we are their assistant. We do what they tell us to do. If she says, no, that's how I want it done, okay. Because she may have some knowledge that we don't have about this particular patient. I don't know. So assist the nurse. Like I said, all your nurses may not be completely up on all the procedures as well. It's a lot of material that changes, and we're not always able to keep up with all the changes. Some of them might slip by us. For instance, slipper socks. That's probably the biggest one you're going to face right now, is because in a clinical setting, it's very, very common to have patients walking around in slipper socks. Nobody wears shoes. Nobody wears shoes. And you're going to tell the nurse, hey, I learned that patient had to have shoes on, and the nurse is going to go, whatever. And they're not going to take it seriously. So all you have to say is, I'm not, I don't know how you want, or I'll do this however you want me to do it, but there are pathogens on the floor that are going to get back into bed with that patient. Just plant that little seed.
Yeah, I used to have aides and nurses, not like when I used to change the socks constantly. I'm like, well, look at their socks. Why are they going back in bed like that?
Yeah,
Well, we
exactly.
don't have extras like that. But you look like fools because that's disgusting.
Yeah, if you were the patient, how would you?
And they used to train us to put their shoes on in the bed before we turn them out.
Yeah, don't do that.
Common sense should, be
Employed?
yeah.
Yeah, that isn't as common as you would think.
When you bring that up, I'm like, oh, I like that too.
Yeah, remember that the nurse is legally liable for the patient. So all we can do is relay the information that we have in a respectful way, but don't be too challenging because they really are the bosses. Be respectful. Yeah, and you can usually get a little bit further just by, just dropping a hint here and there. It'll sit back there and kind of percolate, oh, maybe I need to look into this a little bit more. Okay. So drainage bag. Here are our principles. Nothing new to learn here. Nothing new. Down here is the test specific information. You have 9 minutes to do this skill. It's going to be done on a mannequin. It really doesn't matter who's in the bed because we're really not doing anything with the patient for this skill. Right? We're draining the bag. But we are still going to talk to the patient. We're still going to do our opening and our closing, so it doesn't matter what's in the bed. Charting is required, and you can be off by 50 cc's in either direction for this particular skill. And our care plan at the top of page 165 tells us to empty the resident's urinary drainage bag into a graduate container, measure and record urinary output in mLs or cc's. Remember, we always use mLs or cc's in medicine. On the intake and output form. So this is a triangular graduate container. You only want to touch it when you have gloves on. Don't do as I'm doing. This has never really held real urine. But when we use this, we just rinse it, dry it, and store it. So we don't even use soap. You don't want to touch this without gloves. Right, it's just their urine. So this is how we're going to measure. One side is in ounces, the other side is in cc's or mLs. We're going to round to the nearest line. So I'm going to pass this around so you guys can all see. And yes, this is in the practice kits as well. So you're able to actually use the same materials in practice that you're going to be using on the test. Step-by-step instructions there. Okay. Melissa, Nurse Patty, if a patient is always waking up in feces all over her bed, her hands, and hair, what can I do to stop the reoccurrence? Okay, there's a lot to unpack in that one. All right, so first of all, if they're always waking up like that, I would, as the nurse, I would have somebody doing checks on the patient every hour. Because you don't want them waking up like that means that they've been laying in it for probably some time. So I would want this patient checked. We all have, how do I put this? We all have bowel routines. Like most people have a certain time of the day, generally, that they have bowel movements. We're pretty routine as a species about that. So if this patient is waking up after having a bowel movement, that means that their bowel patterns are probably sometime during the night. So I have lots of questions here. Is the patient able to use a bedpan? If so, then maybe we need to make sure that they're put on a bedpan. Is the patient incontinent, unable to control their bowel movements, the feces that are coming out? In that case, if they can't control it, then whenever stool arrives to the anal opening, it's just going to come out because there's nothing there to keep it in place. So in that case, possibly a adult brief would be indicated during the nighttime to help control that. Now, all over their hands and hair, that takes a while. And that's the part that I'm kind of focusing on when I'm saying this, that this patient probably needs to be checked on about every hour throughout the night, because hands, if your patient has dementia, when feces comes out, it's foreign. It doesn't, you don't expect to wake up in a bed full of feces. Right. So that patient's probably going to reach down and kind of feel around, what is this? Especially if they have dementia, what is this? Now, if that patient now has feces on their hands and they put it up to their face, that's a huge infection control risk. Huge. That's just not. So how would I handle this as a nurse? Depends on the patient that I'm working with. Is it a psych patient? Now, psych patients are completely different. Psych patients know what they're doing, but they have some sort of an impulse that they can't control. That's different than a dementia patient. That dementia patients are different than somebody with incontinence. So I can't give you one answer that's going to cover every base here. But I certainly would start with check on this patient every hour, because it takes a while to get from bowel movement to hand to head. That's gross. So we need to help that patient maintain hygiene. If they can't do it themselves, then it's up to us. Good question. All right. So different drainage bags are going to be emptied a little bit differently. We talked about the bedside bag with the port, and we've talked about the leg bag with a port that gets unscrewed. So usually, in most cases, if your patient is using a leg bag, they're probably going to empty it themselves. In most cases. Not always, though. Some patients who are paraplegics or quadriplegics may not have the dexterity to be able to open a leg bag. So again, go by your care plan for that patient. Both of these are connected to the catheter the same way. They're going to be emptied a little bit differently. When we empty the drainage bag, that graduate container is going to go on a chucks on the floor right under the bag. So we put our chucks on the floor. We get our gloves on, put the cup on top of the chucks on the floor. And then we're going to empty the urine into the container. That's it. You just empty it. But you don't want that port to touch anything, not the container, not the bed, not the chucks, not the drainage bag, nothing. It's got to stay clean. This is a T valve. You guys all had a chance to play with the catheter bag. This is a T valve. So we pull it out of its house, we open the T, and the urine is going to come down into the cup. Do not lift this bag up above the patient's hips to drain the urine out of it. You can lift the bag a little bit, positioning, as long as it's not above the level of the patient's hips. So yeah, you can move that bag a little bit to help it drain more efficiently.
Further clarification on that question.
Okay. I do feel she has no control of her bowel movement, but she wears Pampers and she takes it off and she's bedridden. Okay, so first, we don't call them Pampers. They're adult briefs because Pampers is a child term. And it sounds like she probably has dementia if she's taking it off and she's bedridden. So I would talk to the nurse about this particular situation and find out the best way to handle it. I can't give you the answer that you're looking for because I don't know the patient or the staffing or the facility or anything else. I don't know how to tell you to solve that situation because every situation is going to be a little different. Check with your nurse. So we have this graduate container that we had urine in. We emptied from the bag, put it in the container. We're going to take this container to the bathroom to measure. Now, when we take it to the bathroom, remember I said we don't carry an open container of urine through a room? So we're going to take that chucks, wrap it around our container, take it to the bathroom. When we get it to the bathroom, we're going to unwrap it, and that container needs to be very specifically on a barrier, on a flat surface, and we have to read it at eye level. That means that you've got to get down and actually read it at eye level to measure it appropriately. So on a barrier, on a flat surface, at eye level, all three of those are on the same checkpoint line. So if you don't get all three of them, you don't get any of them. We're going to use the lid of the toilet to put our cup on. It's going to be a bedside commode. So you just put the chucks and the graduate on the lid of the bedside commode, get down at eye level and measure. You can round to the nearest line, up or down, doesn't matter. After we've emptied, rinsed, dried, stored our container, checked our tubing, make sure it's not near the floor, check the bag, make sure it's not on the floor, did our closing, all of that is done, we have to document. We're going to wash our hands before we document. Super important. We're going to document on the intake and output sheet, but specifically on the output section. If you mistakenly document up here, you are legally declaring that this patient drank urine. Legally. Got to make sure you're in the output section. You're going to document the time. It does not have to be in military time. You can use regular time, but if you use regular time, you have to indicate AM or PM. You can't just say 11:25. Yeah, because 11:25 happens in the PM too. So we have to say 11:25 AM. Or if you use military time, it's 4 numbers all squished together, no AM, no PM. So 11:25 would simply be 1125. You're going to document the type of output, which in this case is urine. How much output, how many cc's, and that was based on what we measured, and then our initials. After we document, we wash our hands again. So we're going to follow the care plan. We're going to do our opening, put a barrier on the floor, put some gloves on, get our graduate container, put it on the barrier, and empty the bag. Don't let that port touch anything. You can tilt the bag for easier emptying, but don't put it above the level of the patient's hips. Close the valve. Don't let that valve touch anything. Put it back in its house. Wrap the chucks around the container. Take it over to the bathroom. Set it down. And we're going to measure at eye level. Dump it in the toilet. Rinse, dry, store. Remove your gloves. Check the tubing and the bag. Do your closing. And then document. And of course, you're going to wash your hands one last time because we have to end skill with clean hands. Good? All right, so I'm going to show you these two videos back to back. Remember, they are two separate skills, but I like to show them together because they really do go together. When in a clinical setting, when you're doing catheter care, you're going to be emptying the drainage bag too. They go together. So we'll see these two videos, and then the rest of the class you will have to practice.
Catheter care first.
Catheter care first. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Good. I need to do catheter care. Is that okay? I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, Miss Jones, I'm going to gather my supplies. I'll start out with a barrier that provides a clean place to put my supplies. And we're going to get 4 washcloths, a towel, a chucks, a privacy blanket, and now I'll gather my basin and soap. And a set of gloves. All right, Miss Jones, I'll just get some water. I'll be right back. Okay, would you like to check the water temperature and make sure it's okay? It's good? Good. I'll place the washcloths in there to stay warm. And I'm going to cover you with a privacy blanket. This is going to help protect your privacy and keep you warm while we do this skill. And I'm going to pull your sheet down to about your knees. Okay, Miss Jones, I'm going to place this pad underneath you. This is going to help keep your bed dry while we do this skill. First, I'll roll it toward me. And place it on the bed. And then I'll put my gloves on. All right, Miss Jones, can you scoot toward me, please? Thank you. And can you roll onto your left side? 1, 2, 3. Thank you. I'm going to be very careful, making sure that the catheter tubing rolls with the patient and doesn't get pulled on. I'm going to unroll the chucks underneath the patient's hip and have the patient come back onto their back, making sure that they don't lay on that catheter tubing. Miss Jones, can you scoot to the middle of the bed, please? Thank you. Miss Jones, can you scoot toward me? Thank you. And roll up onto your right side. 1, 2, 3. And now I can unroll the chucks to protect the bed. Come on back, Miss Jones, and scoot to the middle of the bed. Thank you very much. Okay, now I'm going to start cleaning the catheter. I'm going to roll your gown up inside the blanket. I will be exposing you, but we'll make this as brief as possible. Please let me know if you're uncomfortable. As I roll the gown in the blanket, I want to make sure that I don't grab the catheter, that we don't cause any unnecessary pulling or stress on that catheter. And now we'll cover her thighs with a towel. This exposes only the area that we're working on. I'm going to take the first washcloth and wring it out and apply soap to 4 leaves. 1, 2, 3, 4. Now I'm going to clean your catheter. I'm going to hold the catheter where it exits the body, wrap the washcloth around, and wipe away from the body. Fold that leaf over. I'm going to hold it, wrap the washcloth around, and wipe away from the body. That's 2. We're going to do this 2 more times. Away from the body. 3. And the last one. 4. I'll set this washcloth aside. Whenever we wash, we must rinse. So I'll wring this washcloth out, and we'll use it to rinse that catheter the same way we washed. I'm going to hold it where it exits the body, wrap the washcloth around, and wipe away from the body. We'll do this 4 times. 2, 3, and 4. Set this aside. Now we'll dry the catheter. Now we're going to do peri-care. We'll take a washcloth out of the basin, wring it out really well, and we're going to soap 5 corners. 1, 2, 3, 4, and the back side is 5. Okay, now I'm going to clean the peri area. I'm going to lift the catheter up out of the way with my pinky and hold the labia open while I clean down the center with the first leaf. Always going top to bottom. And then we'll remove the washcloth and fold that leaf over. Now I'm going to clean down one side of the labia, top to bottom. Fold that leaf over. Clean down the other side of the labia, top to bottom. Fold that leaf over. I'm going to clean the skin fold between the groin and the leg. Fold that leaf over. And clean the other skin fold between the groin and the leg, and then set that washcloth aside. I'm going to take the final washcloth and wring it out really well, and we're going to rinse all of those areas the same way that we washed them. So I'll hold that catheter out of the way and spread the labia open, cleaning down the center, top to bottom. Fold that leaf over, clean down one side of the labia, fold that leaf over, rinse down the other side of the labia, fold that leaf over. We're going to rinse the skin fold, fold that leaf over, and the other skin fold. Set that aside. Now we'll dry gently by patting dry top to bottom and then removing the towel. Ms. Jones, I'm going to cover you back up. I'll unroll that blanket, which will replace the gown over the patient. I'm going to make sure that the catheter and the tubing is coiled on the bed, not near the floor and not where the patient is laying on it, making sure it's not kinked. Ms. Jones, I'll be right back. I need to dispose of your supplies. The towels and washcloth will be placed in dirty linen. The basin is going to be cleaned the way we clean everything else. We'll return the basin to the drawer, and on the way we'll pick up the soap. We'll open the drawer with the paper towel and return the basin to its storage area. Now I'll dispose of my paper towels. Okay, Ms. Jones, I need to remove the chucks from under you. Can I get you to scoot toward me, please? Thank you. And can I get you to roll up on your left side? 1, 2, 3. Thank you. I'll roll this soiled chucks toward the patient and tuck it under her hip. Come on back, Ms. Jones. And scoot back to the middle, making sure the patient is not laying on that catheter tubing. Okay, Ms. Jones, can you scoot toward me again, please? Thank you. And roll up on your right side. And I'm going to remove that chucks from the bed. Okay, you can scoot back to the middle. Thank you. This is going to be thrown away. Okay, Ms. Jones, let me just look at your catheter one last time. Make sure that the catheter tubing is coiled on the bed, that the catheter is not on the floor. Everything looks good. I'm going to remove the chucks from the table, and we're going to throw this away, and then I'll remove my gloves. We'll throw those away. Okay, Ms. Jones, I'll pull your sheet up now. And I'll remove the blanket as I do so, rolling it into a ball. You put this in dirty linen. Okay, Ms. Jones, here's your call light. If you should need anything, just let me know. Are you comfortable? Can I get you anything while I'm here, like a magazine? I'm just going to open your curtain and wash my hands. After washing my hands, I'll think about the steps in my skill, make any corrections that need to be made, and then tell the evaluator my skill is done. Okay, so real quick before we roll into the next video, there's something that I did want to mention. It does not matter whether you clean the catheter first or the peri area first. Either is fine. So, however you want to do it is fine. I did get a question real quick that I want to address. Helen asks, in what situations do we use the Red Robinson catheter? That is not something that a CNA would decide. That is totally and completely up to the nurse. The CNA would have zero responsibilities regarding a Red Robinson because we don't empty them. They're not attached to anything. They don't stay in. That is a completely nursing situation, but you need to know that those types of catheters exist. That's why I showed it. So let me show you this last video. Now this is the new format. So on the screen, you're actually going to see the actual testing checkpoints that what I'm demonstrating will check off. So remember this one is the new format. Good evening, Mrs. Jones. How are you today? Fantastic. I need to empty your urinary drainage bag. Is that okay? I'm going to close your curtain for privacy, wash my hands, get my supplies, and I'll be right back. After washing my hands, I'll get my supplies. We're going to start with the chucks. This is going to go on the floor under the bag. We're going to place the barrier on the floor directly under the urinary drainage bag. So we'll unfold it and we'll place it under the bag with the absorbent side facing up. I'm going to go get a set of gloves. And we're going to get the graduate container out of the drawer. You need to make sure that you put your gloves on before you get the graduate container. We're going to place the container on the barrier directly underneath the bag. We use the emptying port to empty the bag. This is a T-valve. We slide it to the side to open the valve, and then we're going to empty the urine into the graduate container without letting that port touch anything. Once the bag is empty, we'll close the port and place it back in its little house. All right, Ms. Jones, I just want to check to make sure the tubing is coiled on the bed and you're not lying on it. And that it's not coiled near the floor either, where it could become a tripping hazard. Now, I can wrap the chucks around my graduate container for safe and secure transport to the bathroom. We're going to set it down on the lid of the bedside commode and unwrap it, turning the cup around so that we can read the amount of urine that's in the cup. We need to be at eye level. It needs to be on a flat surface and on a barrier. I'm going to throw the chucks away. Open the lid and the seat and dispose of the urine into the bedside commode. I'll rinse the cup and dispose of the rinse water into the bedside commode as well. We'll close that, set the graduate container down in the sink, and disinfect it per facility policy. I'll pick it up with a paper towel, dry the inside with a paper towel, throw that away, dry the outside with a paper towel, throw that away, and one more for the drawer. Okay, Miss Jones, I'm just going to return this to storage using a paper towel to open the drawer. And closing the drawer, we'll throw those paper towels away, and then I can remove my gloves. You take a peek at your tubing just one last time. Everything looks good. Are you comfortable, Mrs. Jones? Is there anything else I can get for you while I'm here? No? Would you like a magazine before I go? Your bed is in a low position. Your environment is clean. I'm going to open the curtain. Here's your call light. If you need anything at all, just press that red button. We'll be happy to come back and assist you. Thank you very much. I'm going to go wash my hands. After washing my hands, we'll document the amount of output on the documentation sheet provided by the evaluator. We're going to document the time of output, the type of output, which is urine, the amount of output in cc's, and my initials. And we want to make sure that we're documenting in the output section. After documenting, I'll wash my hands one final time. After washing my hands a final time, I'll review the care plan, make any corrections, and then tell the evaluator my skill is done. Did the checkpoints help being listed on the bottom? Do they help? I'm hoping that it'll show you why you're doing certain steps, that they're there specifically to check off a checkpoint. Oh, am I unmuted? Yeah,
Yes.
I'm good. All right. So anyone have any last questions for me? That's it.
Where do you film the videos at?
That was my previous, that was the classroom that I had for 17 years that we just left.
Oh,
So I'm actually in the process right now of creating an entire taping studio at my house. We have a whole section that we're using that has the bathroom, and I'm converting a large room into a taping studio. So you'll see lots of new videos coming. Super excited about that. They actually started working on it this week, and I'm really happy. So hopefully within the next 4 to 5 weeks, I'll be able to start taping in my new studio. All right, so any last questions? You guys all have your review sheets for today. On Wednesday, you need to bring your yellow book back, please. I will be collecting that yellow book. The white book is yours. The spiral book is yours to keep forever. We will be going over continuing education, employment, questions you need to be asking during an interview. We'll talk about how to find a job because it is different finding a job in healthcare than other industries. And probably some of these differences you're not aware of. So I'm going to give you some insider tips. And then we're also going to craft our tell me a little bit about yourself speech. There's a formula that I'm going to give you to use that makes it super easy to figure out what you should say when somebody says, tell me a little bit about yourself. And if you use this formula, you're you're guaranteed to perform better on an interview than others. Okay, so I'll go over that as well. So we have stuff to cover on Wednesday. We will take a class photo as well. So please make sure that you're in, your t-shirts so that everybody looks the same. Other than that, if you don't have any questions, the rest of today is just practice.
The practice test that you said that you have listed or in the book or whatever, that's as close to the written.
Yep.
Is that the one in the back of this book?
Right. So page 192 in your white book is a full 60 question practice test, very similar to the state exam. If you miss 5 or less, because again, that's okay. That's okay. If you miss 5 or less on my practice exam, yeah, I should lock the door. If you miss 5 or less on my practice exam, you're ready for the state exam. I've never had a student of mine that's been a classroom student that missed 5 or less that failed the written. So it's a pretty good indicator of how you're going to do. I also have lots of practice questions in the online course, which you all have access to. And we have a practice test on my main website as well, 4YourCNA.com. So lots of practice opportunities. But guys, the written test is not really the one that is going to be hard for you. You're going to read the questions on the written test and go, oh, that's easy. Sure, yeah. Because you've got the information that you need. It's the skills that you really need to be focusing your time and attention on. Any others? That's a great question. Any others? All right, we're going to go ahead and sign off of online. Thank you guys so much for joining us. This wraps up the skills for this session. We are done with skills. Yay. Please make sure you tune in tomorrow at 11 a.m. on my YouTube channel for the game show, and that'll go over 15 test-like practice questions. If you go to my YouTube channel, I've got a whole playlist of those game shows. Each one has 15 questions. There are, I think, 500 questions in that, in that playlist now. So it's a great way for you to kind of see the types of questions you would see on the state exam. So we will see you on Wednesday for graduation. If you have any questions, please feel free to get in touch with me via my website or social media. Until next time, guys, happy caregiving. Bye.